Hey everybody, welcome. Let me know if you can hear me. Sounds okay. Hello, hello. Kaylee. It's Kaylee, right? Hey, Paige. Perfect. I just see the C Mace, so I had to make sure that was getting that right. All right, we're in Epi Bio today. Get started in a few minutes. This will be either your most favorite class or could be your worst class. We'll have to see. But we'll get started in a few minutes. Give people a chance. Come on in. Hey everyone. How was cardio? I'm sure that was a bit of a brain buster, similar to the first day of farm. Okay, mainly anatomy review. That's good. It's a good way to ease you into it. I decided to go the opposite approach, and I did the just blast you with as much information as possible, and then we'll go from there. The weather is nicer today, so it's not quite as rainy. So hopefully it looks a little less dreary on my end. And if you see me get distracted, there's like birds and bugs and people walking by in front of the window, so it's likely my ADD sort of acting up a little bit there. Allison and Aaron and Cassette. Good to see everyone here. I don't think I'll get the same turnout as for farm, but that's okay. People can watch later. Sunlight is nice. It dries my tears faster. Oh, well, I'm sorry you're having tears, Brian, but this class may not help, so I apologize for that in advance. Imagine most of you are feeling that way. That's good, especially because we are stuck indoors and at home. Make sure you get outside and get some vitamin D therapy. Get some. That definitely can affect your mood for sure. So we need as much positivity as possible. Yeah, tissues might need to. I should have bought some stock in Johnson and Johnson. Whoever makes Kleenex or something. That probably been a good idea. Matt is saying, or Matthew was saying, stats was easy in undergrad. I take it this is way different. I don't know. I think I find a lot of people will either have kind of two reactions to it because I think most everyone took stats. I think that's a requirement. They either feel like this is like a real scaled back version of that because like I'm not getting into SAS and all that kind of fun stuff. Or some people find it more difficult because this is a much more conceptual sort of class, more so about interpretation of the literature than it is necessarily about doing the stats yourself. So we'll see. Hopefully today will be mostly a review for a lot of you. It's but we'll get into it in just a minute here. Got 37. That's pretty good. Not too shabby. Like I said, these ones are going to be. I'll talk about the schedule in just a moment here once we get moving. Yeah, it's probably the biggest reason why I don't have you guys do Zoom with me all the time in farm is because I just see a bunch of ugly crying the whole time. But I said, well, I'll spare them that indignity and just let them hide it on without the camera. So. All right, it's about time. So let's see. All right, so I have started the backup recording here. Welcome to Epidemiology and Biostatistics, the second course that I'll be teaching you during the fall semester here. Very different vibe in terms of what we're covering as compared to farm, but we'll see how you like it. I think some people will find this a little dry. Some people may struggle to find how this is applicable to your future practice as a PA, but I promise I will try to make this as clinically relevant as possible and how you're going to be using this hopefully on a near daily basis, not just in your or not just in professional life, but even in your day-to-day life. You might run into stuff that concerns us all the time, as we'll see. Basically, what we're going to go through today is I want to get you kind of oriented to the course. We'll do a little bit of an introduction PowerPoint, and then we'll start to get into it. Just kind of go over some basic stats reviews before we get into the kind of meat of the topic. You know, my reviews for this class always tend to be a little lower than my farm stuff, and I take that with a grain of salt. I know this is not for everyone. But my favorite review comment ever was that they said that this class is like a big bucket of sand, and I'm trying to tell you to dig in. But fortunately, I at least made the first bite go down a little bit smoother. So, as I said, it's a dry topic, but I always thought it was a pretty good analogy for that. So, anyway, looking at the course, you can see here the schedule. Notice that all of the YouTube links are going to be sort of optional attendance. Hopefully I don't see my concurrent viewers like drop down. I got like 47 right now. Hopefully it doesn't go down to like 2. These will be optional. They'll be recorded. You can go back to them and review them later. You don't have to be there in real time. I like it if you are, because that allows us to have some interactions, and I can uncover some, you know, maybe gaps in understanding right away, right? If you see where it says, if it's a Zoom session, you have to be there, just like normal for your other classes. It will either be a review or it will be one of our journal clubs. And that's actually going to be one of the main points for your grade, as we're going to see here in a little bit. The first journal club will basically be me sort of walking you through an article that is recent and pertinent to your guys' interests. We'll kind of go through, how do you dissect an article? How do you go through it? How do you figure out what's the good information, what's the bad? How do you figure out what to take away from an article in order to take care of a patient, right? That's the important thing here. And then when we have future journal club sections, I'll actually be assigning you guys into groups. You will then work together, probably in some breakout rooms, in order to analyze the piece of literature, and then you'll bring it back and we'll kind of discuss it as a group and kind of be able to go through and kind of see what we think about the literature. And so that's really what this class is about, is not necessarily how to do stats in and of itself. It is more so of how do you read an article within the medical literature, how do you interpret it, and how do you figure out what to even take away from it. How do you determine what a good article is versus a bad article? How do you determine, you know, when you're looking at a p-value or a set of confidence intervals, what does that mean for the patient that's right in front of you? Because the question isn't going to be, you know, does this drug work, yes or no? It's going to be a patient coming and asking you, hey, I heard about this hydroxychloroquine and how it can like prevent COVID, and there were some articles about that. What do you think about that? And you may be like, I have no idea what the heck you're even talking about. But if you're able to at least find the literature, evaluate it, you can then come back fairly quickly to that patient and say, yeah, this is great, or no, it's not great, and hint, no, it's not great, but that's okay. So, and I'll try to make it applicable to the real world, because we're actually in a big kind of scary time right now where it's difficult to determine, like, who do you believe? Like, just because someone says they're an expert doesn't mean that they really know anything, or that the things that they are reporting on are accurate. There's actually a really big issue that just popped up. It was I think just past Sunday, and I think it was the head of the FDA was FDA or CDC. I have to go back and check the article, but they were making some claims about an article, and they had totally misinterpreted it. They totally took away the wrong findings from it, and they were saying that to the entire nation. And it wasn't until a bunch of other people came behind him and said, this is wrong, you got to make a retraction, and eventually he did. But even the experts can make really big mistakes, and so that's kind of what I'm trying to get at here, is try to introduce you to this topic and learn kind of what you can take away from it to apply back to your patients. Okay, so anyway, so here's the course. You can see the schedule here, and all of that. You see the exams are also on there as well. There's no like there's like homework assignments. We don't really have those in here. The journal clubs are all going to be group based during the actual lecture time, during that 2 hours here. If you're looking at the modules page, you'll see that there's a sticky board, which I imagine some people will need to use in order to ask some anonymous questions, so you can post that there. I also have the journal club topic survey. This is something I would like all of you to do. You can even do it right now if you like. Click on that, and it's a quick quiz. And basically all you got to do is go through and just pick out like which topics are you kind of interested in reviewing the literature on. You know, do you like behavioral medicine? Do you like pediatrics? Do you like cardiology? click any, none, all of them, it doesn't matter, and then submit that. It's not for a grade, it's just so that when I go through, I can look to see like what are the most topics that you guys are interested in, and I can then pull recent articles from that area and show it to you. Because I find that if you're reading things that you're really interested in, you're more likely to have a good time reading it and more likely to be engaged. Because I can bring a whole bunch of pharmacy journals or toxicology journal articles your way, but if you don't really care, then you're not going to be all that engaged. So that's the main thing I'd like you to do for that, if you don't mind. There's no time limit on it or no due date, so whenever you get to it, but right now would be a fine time to do it, I think. Here's the syllabus as well, which you can go ahead and find. Notice that's not published right now, but you can see the first couple of PowerPoints here that you can check out. We'll get through probably 1 and 2 today. And then look at the syllabus. The main thing I want to draw your attention to is going to be how the course is sort of laid out in terms of grades. This class is fairly forgiving because a big chunk of it, about 40%, is going to be basically your participation in the journal clubs. And so you guys will have a document you'll turn in at the end of those, and that will all go into your grade there, right? So it's not a participation grade, but you're participating in these journal clubs and then turning in a deliverable to me, and then that's going to be the grade for that. The 2 exams are going to be over, the first section will be over the biostatistics section, first half, and then there'll be an epidemiology section specifically after that. Similar sort of format to what you're used to. 50 questions, 4 answer choices, multiple choice. You may get some questions that are like, okay, well, what's the definition of a median? Like, okay, that's, pretty basic stuff, which might be, a certain percentage, but, you're gonna have a lot of questions where I actually give you, say, like a section of an article, and I say, okay, well, what can you interpret from this? Based off of this, what do the findings actually show? And so that's where your interpretation skills are really going to come into play, and we'll do some review questions, and you'll have some ideas kind of about what I'm really looking for there. So I think that about covers how the course is going to be broken up, and if you have questions, feel free to post them in. So I got about 2/3 of the class, which is pretty good. So I'm glad you guys are here with me for that. I'm surprised the 2:30 time frame. I figure everyone's going to be running out of glucose and laying down for a nap, perhaps. But if you have insomnia, I also have the additional benefit of being a very good cure for that. So don't you worry. You can just get a little pillow, maybe some melatonin, some chamomile tea, and just lay down for a nap, and you can watch the video later, and or you could even absorb it all via osmosis. That could work too. I made a 0 on the survey. I know it's at a 0, but it still hurt a little. Oh, Aaron, I'm sorry to hurt you that way. I'll change it to 1,000,000 points, and it just won't count towards anything. And it doesn't feel really good when you get 1,000,000 on it. It was time for naps. You should always make time for a little nap. Even 20 minutes can really help reset things when you're studying hard. Anyway, so let's get into the actual introduction to statistics itself. You can read through the objectives and see about that. I'll just give you like random quizzes, like here's a Tuesday quiz that's worth 4 billion points, and I don't even know if Canvas will support that. Hopefully I don't screw up everyone's grades that way. Anyway, so statistics, I think this quote really sums it up. 60% of the time, it works every time. If nothing else from this class, I think you're going to learn that you never are going to be 100% sure of anything. And so if you have that inclination, if you feel like you always have to be right about something, let me tell you, that's going to go away with time, right? You're going to figure out that you don't always have the answer, and even if you think you do, there's always a chance it's not going to be, right? A patient could ask you, hey, what are my chances of dying if I go to surgery? And you could say, well, you're not going to die. But that could be false, right? They could have a bad reaction to anesthesia. There could be 1,000,000 freak accidents that could happen, even if it's a relatively safe procedure. So what you're going to learn through here is you always want to be able to hedge your bets a little bit and be able to say, well, most likely this will happen, or this is very unlikely to occur, or based off of this, I think that this is the thing that's going to happen. But you always want to leave yourself a little bit of wiggle room, because people will prove you wrong all the time. You can say this medication is going to be really good to treat your infection. You give it to the patient, and the infection does not go away whatsoever. Well, because you were making an educated guess, you're taking a chance, you're gambling in a sense to say that, okay, this patient has otitis media. I most likely think they have these bugs. I'm going to give them this drug to cover it. But you could be wrong, right? So you have to say, well, this drug is most likely going to treat that, but it may not. We may have resistance. We may have a different bug altogether. It could, so you're going to learn about that, and this class will help you to sort of work through that and kind of figure out from the statistics side why that actually is. And because as people, we tend to jump to conclusions, right? So even if we have new data that is something that should alter our mindset or what we think is true, we have a really hard time of throwing that away. We have a really hard time of throwing away our preconceived notions to come to a new conclusion, right? I'm sure you see that in people all the time, where if they are really sure if something is right, they don't want to hear anything that's contradictory to that. They like their echo chambers where they can keep hearing about how right they are, and anyone else is just quote unquote fake news, right? That's something you'll hear quite a bit nowadays. So let me give you a real life example of how new data can be useful to change your mind, and using statistics can actually help. So this is a real world example that worked for me and my actual benefit here. So let me take you back to a, yes, Facebook is the world's biggest echo chamber in a big sense there, but let me take you back to the heady days of, let's see, 2011, 2012. You guys might have been in middle school at that time. I'm just kidding. You guys are pretty young though. But anyway, I was recently engaged to my now current wife, and we both needed jobs. We're both finishing up our second years in residency and fellowship respectively, and we needed a place to move to find a job. And so I said, okay, well, Orlando has a pretty good job pool right now for pharmacists. Let's go ahead and search down there. We both got jobs. It's like, great. Okay. So I said, okay, well, we're going to live at this place. What do you think about this place? And she goes, oh no, I'm not moving in with you. And I said, what? Like, I said, we're engaged. Like, why shouldn't we move in? It costs less, half as much money too. And she said, well, we can't move in together because that increases the risk for divorce. So I said, well, what's your source on that? And she goes, Cosmo. I don't know if you guys are familiar with Cosmo, but I wouldn't necessarily compare it to the likes of, you know, the New England Journal of Medicine or JAMA or anything like that. So I decided to actually check out the literature. I wanted to find out, well, what are the risks for divorce, and does it actually increase when you cohabitate prior to marriage, right? So I went ahead and actually found a study from the CDC, no less, that says marriage and cohabitation in the United States, a statistical portrait. And I said, this is exactly what I need. I was a little old at the time, but basically what I was able to find is they said that previous cohabitation experience was significantly associated with marriage survival probabilities for men. In general, men who cohabitated prior to their first marriage had lower probabilities of the marriage surviving in the 10th anniversary than those who did not cohabitate prior to the first marriage. And I said, oh, I'm sunk. I can't do it because, look, this actually says that men, or their first marriage, they cohabitate, the risk are higher. She's right. Cosmo was correct until I read a little further. And then it said those men who were engaged at the time of cohabitation with their soon-to-be first wife had similar probabilities that their marriage would last 10 years, as did those who did not cohabitate prior to marriage. 71% for men who were engaged in cohabitation, 69% for men who had never cohabitated. So I said, boom, got him. So I said, that's telling me right there. We're engaged beforehand. We show commitment, so perhaps our chances will be similar. So then I showed it to her, and then she grumbled a little bit and said, okay, fine. So question is, did it actually work out? Well, we're actually having our 7-year anniversary this Sunday. So in 3 years, I will tell you the update, right? So you'll be able to come back and find out, did that work or not? Okay. So anyway, that's a true story though. Yes, thank you. I don't know if she feels the same way, but I thank you. Anyway, so basically as human beings, we are hardwired to be able to generalize things, right? We look for patterns even if ones really aren't there. And that's why we need statistics to be able to really look at those data points and try to draw actual conclusions out of those, and not just using that limited amount of data. For instance, I'm not a huge I'm not huge into sports by any means, but sports is a big area where people look for statistics. I always love like the records that people will get, like they're the first third string player to be left-handed and jump on one head and pat their belly. It's just weird stuff like that. But anyway, point being, oh, you were in middle school? Oh, that hurts. That hurts so bad, Selena. Oof. Billy Allison. But anyway, so there's this idea in basketball that if you get a few shots in a row, that your subsequent shots are more likely to be made. And so they were looking at this data and they're trying to figure out, like, does this actually hold true? Does having successful shots beget more successful shots in the future? And is the opposite also true as well, right? That's what I always thought too, that fantasy football is just D&D for jocks, for sure. It's all statistics. It's But anyway, so looking at that, they were trying to plot this out, and so an X would be a successful shot, and a dash would be a miss. And so the question is, like, if you're looking at this, does it appear that there actually is something to this, right? So you're looking, okay, well, does one shot beget more shots? And if you were to look at it, you would probably say, like, yeah, it actually kind of looks like it, right? So you got like 5 shots in a row here, and you have 4 shots. They look like there's clusters there. But if you actually look at it, it's completely random if you do the statistical test on it. So even though people will look to see patterns there, their patterns might not actually exist. And so really it was about a 50-50 shot of whether or not they're going to make it based off of the previous shot that they had made. So again, it just goes to show you that not everything is just based off pattern recognition, but that's the way our brains are evolved. We see the sun go through its normal cycle every month, and we can plan our calendar based off of that. That's what our ancestors did, and it works up to a point. But when we're trying to figure out, is surgery the right option for this patient, or is this drug going to work for this patient, we got to be a little bit more rigorous about that. And so that's why we do things like do randomized controlled trials. That's why we do things like blinding. That's why we do all these things, to try to make sure that we limit the human interaction there, and just to figure out what the numbers are really trying to tell us there, right? And again, coincidences happen all the time. Even though the chances of something happening might be extraordinarily low, things still happen all the time. And so it kind of can be sort of counterintuitive when you kind of think about it. And I apologize if there's any increase in noise. My family is just coming back from the family's house. But anyway, so anyways, you're going to see here that, uncommon things happen all the time. It's just a matter of how those things sort of line up and happen. But let's look at an example here of unlikely things that end up being likely to happen when you have a large enough sample size. So this is something called the birthday paradox. And this is something I normally do in the class when I have all 62 of you present, and this actually works out pretty well. But the chances are, what are the chances that 2 people in this class have the same exact birthday, right? Now the question isn't what are the chances that someone has the same exact birthday as me in the class. I'm just saying any 2 people in the class actually happening, right? And so given the fact that we have 63 individuals, me plus 62 of you, 50 of which are here, and there's 365 days in the year, the probability of someone being born on any given day is only 0.27%, right? Because 1 divided by 365. And the chances that someone else is born on the same day as me is roughly equal to that. So 1 out of 365. So the chances of me having the same birthday as any one of you is quite low. But the chances of any 2 of us having the same birthday, it actually ends up being pretty high, right? So if you actually look at it and you do all the math that goes into it, right? And there's calculators you can do online for this. I don't want to bore you with that. But the probability that 2 people will share the same birthday is 99.7%. That's incredibly likely to happen. And normally I would have people kind of go down the rows and list out their birthdays, but I bet if you did the same thing right now, you would find that at least 2 people, probably more as the case may be, all have the same birthday, or at least a few pairs of people. So pretty cool thing when you actually think about it, being the fact that the chances of me having this unlikely thing occur is quite low, but any group of people having this is quite likely. Yeah, I wish happy birthday to 2 people at a time, 2 people a few times. Okay, Cassian, you have the same birthday. See, so it already proves me correct. The chances were just very good for that happening. So thank you for further upholding the birthday paradox. But, and again, people oftentimes have, let's see, I remember saying it's a classic birthday paradox in the chat too. Very good. Yeah, so, and people oftentimes have kind of like incorrect intuitive feelings all the time. So imagine you have a bowl or 2 bowls full of jelly beans, one's small and one's large. And the small one has 9 white and 1 red in them. And then the large bowl has 93 white and 7 red. And then if you win a prize for blindly sort of picking 1 red bean, sorry, my child's out there running in the yard, so I was making sure their mom was going to go grab them. If you win a prize for blindly picking 1 red bean, which bowl would you pick from? And so what it turns out is that most people tend to make sort of the illogical choice, because which one would you pick from? Well, they probably think, well, 7 red sounds like more than 1 red, so why not go for that one? Even though if you were to look at this, your chances of pulling a red one in this one are only 7% versus in this one it's 10%, right? But again, people are not necessarily very logical when it comes to logic. Or let's apply this to something a little more clinical. Imagine you're looking at a risk for cancer developing, and you're wondering, okay, which one sounds worse? Well, if you're looking and describing as 1,200, almost 1,300 people of 10,000, or if you were to compare it to 24.14 out of 100 people, which one actually sounds more deadly? And so a lot of people say, well, 1,200 sounds pretty bad versus 24, even though the second one actually has double the risk, right? So the risk for cancer in this group here would be much higher, double, twice, you know? So, but people are not really that well versed in being able to figure that sort of thing out. So that's sort of the challenge here that we're working with. And again, just like with Facebook, things are not working off of logic in a lot of cases here. People also don't like to think about sort of like ambiguous situations. They like to know all of the information going in, and in medicine we frequently don't have that, right? So again, imagine we have two urns, we can't see inside of them. Each one of them has 100 beans in them. The first one we know has a 50-50 mix of red and black, and then there's a second one, we don't know the ratio, it's unknown, but it's still a mix of red and black. And then the question is, well, which one would you go for? Which one would you reach for to make that decision? And so most people tend to choose the one where they know it's 50-50, even though I've said nothing about the ratio in the unknown urn. There's nothing to say that it's not, you know, 1 black and 100 or, you know, 99 red, right? There's nothing to say that, but because we don't know and we have a fear of the unknown, people tend to work illogically, right? Even though honestly it really wouldn't matter which one, I'd probably pick the one with the unknown ratio because it's 50-50 anyway, and maybe more likely in my favor. So that's sort of a challenge we're also dealing with. When people don't know what their chances are of something happening, they get pretty freaked out, right? So again, because that second urn is more complicated, it has some probability and ambiguity, it's pretty tough. And what's interesting is they actually had a study where they did an MRI on patients who were dealing with this sort of problem, and they actually found that it triggered off the amygdala, so that kind of that fear response you have there, and actually decrease activity in the reward center, right? So again, you'd end up finding that people are kind of afraid of that sort of thing. So Brian's saying, I like to live dangerously, mystery box all the way. I say the same thing too. And like, why do you store your jelly beans in urns? This was done back in the 60s, so I couldn't really say. Perhaps the urn market was on more of an upswing back in those days, but where hopefully all of us were not born at that time. Anyway, and so there's a concept here called Bayesian statistics, which we'll actually talk about at the very end of this class here. But it's something where you're using prior probabilities when going into a problem to determine how good a test is for diagnosing a patient with a disease or ruling out that they have that disease. So here's a really good example of using HIV blood screenings. And so let's say if we're just looking at the general population, I'm talking about like population of the US, for instance. Let's say that the prevalence here is 0.1%. So 0.1% of the US population has HIV. And we have an antibody test that's accurate, but it's not perfect, right? And you're going to find this too, that almost no laboratory test is going to be 100% sensitive, 100% specific. And we'll get into sensitivity and specificity a little later on. But the question is like, well, what is the chance of having a true positive test versus a false positive test? Because if you were to take an HIV test, you probably don't want to falsely be told, well, it looks like you have HIV. That's not great. And also you don't want to miss those cases of people who actually do have it. So if I were to take 100,000 people, and I'm going in with the assumption that 0.1% of them would have it, so 100 out of that 100,000, and I would have a test that was 99% specific, we're going to find here, our sensitivity of 99%, what you end up finding is that the test would find positive 99 out of those 100, okay? And then the other 99,900 people would show you don't have HIV, right? Or assuming that's the case here, that's how many people would have it versus not. And so in this case here, because we have a 99% sensitive test, it's going to incorrectly return a positive result in 1% of those people. So what that means is I'm going to have 999 false positives, okay? So 99 people who really had it, and 999 people who did not have it, that were still positive. That means I'm getting a lot of positive results for people who really didn't have the disease. And that means I have a 9% true positive rate. That's not great, right? That sounds pretty poor functioning sort of test there when we're dealing with this population that is, the whole U.S. population in this case here. Or the other way to look at it is 91% of the positive results are false positives. That'd be pretty poor. And again, people would be pretty mad to hear that you're using such a bad test to even look that have HIV in the first place, right? So only 9% chance people really had HIV would actually show there. So, but what if you were to take it and kind of modify it a little bit and work with a prevalence that's a little different, right? That's where the Bayesian statistics really come into play here. Let's look at the same test with the same sensitivity, but now we're going to do it in a different population altogether. Let's look at people who are IV drug abusers. As you might imagine, IV drug abusers are participating in habits that are high risk, and maybe they're not using clean needles, and maybe their risk for sharing bloodborne diseases is higher. So in this population, if you look at 100,000 IV drug abusers, you could say that, okay, well, let's go in thinking there's a 10% prevalence of HIV in this population, right? You assume it's higher because of the high-risk behavior, or if you have previous studies that sort of show you that. The test here is going to be positive in 9,900 of them, so 99% sensitive here. And then the other 90,000 people who don't have HIV, 1% of them is actually going to incorrectly show positive, so 900. What you can see here is we have a lot lower number of positive results overall, and now we have 92% true positives as opposed to only the 9% in the other case there. So by changing the prior probabilities, you can change the results pretty significantly. Now this looks like a much better test by using it in the correct population. We're going to get into that and look at why that really is, and why looking at the population you're dealing with, looking at the tests you're using, how that all can have pretty significant results on what your findings are, and then how you interpret that, right? So again, we're going to be using a lot of baseline data and then interpreting that with the new data that we get from performing a test, and then see what we can draw from that, or at least interpreting that when we're looking at the literature, right? So another thing too is that the multiple comparisons trap is a big one. So one of the things you're going to see when we're looking at studies is we're going to talk about statistical significance. We say, oh, the p-value is less than 0.05. We're going to talk about what that means in a little bit. But basically, you can find that it basically says that there's a 5% chance that the findings that we have are just by chance alone. Just could happen just due to any random set of circumstances. And so the thing is if you keep running a test over and over again, you keep running it over, eventually you're going to find something by accident. Okay. The mantra of even a blind squirrel finds a nut is pretty applicable here, right? Here's a case where they were looking at health statistics for 10 million residents in Ontario, Canada, and they were mining them, right? They were just looking for different data points to connect together to try to find something. And so they examined 223 different reasons for hospital admission, and then they tested that to see what their astrological sign was as well, to see if people with certain astrological signs were more likely to be admitted for certain conditions versus others. And what they found was that 72 diseases occurred statistically significantly more often in one sign than all the others put together. So the question is there a relationship between astrology and health? Could Cosmo help me to determine what sort of health condition my patient might have, right? I think they do horoscopes in Cosmo. I'm not sure. I don't read it too often. Tiger Beat's more of my steez. But anyway, the problem is, though, is that the test was done to try to warn about those difficulties in trying to interpret multiple comparisons and how you can find random connections even though none are there. I think most of us would probably agree that astrology likely doesn't have a whole lot of influence on why people get admitted for cancer versus CHF versus HIV versus anything, right? And so in this case there, because you have 223 different conditions you're looking at times 12 astrological signs, they end up doing 2,676 different comparisons. And just by random chance, you would think that 5% of those would be able to find something just by chance alone. And when they end up finding was 134 statistically significant associations. Now, actually, what's interesting, though, is that by chance alone, 5% of those, 72 should have been found, but they found more than that. So again, not every single finding you have out there, just because someone says, oh, the p-value less than 0.05 means that it's real, right? It doesn't mean that that is actually what the case is. It could still be due to chance. Right? So that's one of the difficult things to look at is when patients or people are reading studies and say, oh, well, the p-value is less than 0.05, it must be true. That's the beginning of the story. It doesn't tell you really anything. You have to look at a lot more information there, right? Or looking at this, we have a study of acupuncture for osteoarthritis, and there were people were asked to rate their arthritis pain before and after treatment, and what they found was that pain decreased in most patients. I'm not saying anything against acupuncture, it's certainly something that certainly can help. But when you're looking at that, they found statistical calculations show a much more consistent findings are exceedingly unlikely to happen by chance. So it says like, well, the acupuncture must have worked, right? The pain scales went down. It was p-value was quite low. Acupuncture must be the best thing in the world, right? Not necessarily, right? Because there are other factors that go into that. Remember, correlation does not equal causation, which is something I'll talk about quite often, right? Sometimes there's other factors you have to account for. So when you hear about studies controlling for gender or controlling for ethnicity, controlling for these things, these are the things they're trying to rule out, right? So could there be placebo effect? Could people thinking they're going to get acupuncture to help their pain think, oh, I got the acupuncture, I think I feel a little better? That could be the placebo effect. The mind is quite powerful in that regard. That's why it's so difficult to do drug studies on antidepressants, because there's such a strong placebo effect. If people who are depressed feel like they're taking something to help their depression, even if it's a sugar pill, it still works in a decent percentage of people, right? So that's why it's so tough. Sometimes people are being polite and they're like, oh, well, thanks for the acupuncture. Yeah, I think I feel a little better. You know, it's like when you get a bad haircut and you're like, yeah, it looks great, thanks. You know, maybe there's other things going on. Did they account for whether the patient has started a new exercise regimen, or maybe some glucosamine and chondroitin for their arthritis? There's several different things here that could be playing a role, and you have to be able to control for these things. Otherwise, it's difficult to say that, yes, this is what happened. Acupuncture led to a decreased pain scale in these patients. You got to rule out all the other stuff, and that's where statistical analysis can be really important for doing that, right? So question is, why are statistics so difficult to learn? Why is this stuff so dense and dry and tough for people to really interpret? And Kaylee's asking, so with the horoscope example, what should we look for to make a diagnosis, and what other people can reproduce the same results? That's a great question. So yeah, that would be awesome if you could run a study and you say that, this drug reduces mortality by 10%. That's all great, but can you reproduce those results? That's kind of the ultimate test. If someone else can do the same study, they find the same results, that leads you a lot more strength in your conclusions, right? Or in the case here, you can just look at the article, and I'll show you some of these tips to look for ways to control for that. In some ways, articles will be done, or research articles will be written such that they say, well, we controlled for the multiple comparisons by doing this correction. There's corrections you can do to help out with that. It reminds me of a story, though. I had a student a couple of years ago who said that they were working in a biology lab in undergrad for this PhD, and they were working with like zebrafish or something like that, and their original study didn't show any statistically significant results, and so they took it to their biology professor, and they said, yeah, we got nothing here. And he says, well, just keep looking, just keep doing a bunch of comparisons until you find something that works. Which is like anathema to, totally antithetical to the scientific process here. But if you're looking to, if your lifestyle is publish or perish, then it may behoove you to do that sort of thing there. So there's always a question of, how reputable is the journal you're looking at? Was it peer reviewed? That certainly helps out quite a bit. But these are all things we're going to talk about as we sort of get through this class here. So what are some obstacles to learning? People don't like numbers. They fear the math that's involved with this. Luckily, we don't have to do a lot of the math. You just have to be able to look at the numbers and be able to interpret them, right? Confusing terminology. When I say something is statistically significant, that means something different than if it's clinically significant, or if I talk about power, or if I talk about, confounding variables. These are things that may have a certain meaning in your day-to-day life, but mean something different in the statistical realm, right? In the fact that it's very abstract in how you're thinking about to extrapolate from an article, and how does that then pertain to your individual patients? And the fact that we're dealing with probabilities. There's never any certainty in this stuff. You could have an article that shows that this is the best thing ever, this is the best drug, and then the next article could come out that completely refutes that. And then you're left going, well, what is it? Does it work? Does it not work? I got the president saying the thing really does work, that I should be injecting bleach, but then I have the whole scientific community saying not to. What should I do? And this is something that, some people actually struggle with. But I'm going to teach you guys how to be able to interpret some of these things and go forward. So anyway, I'm going to try to keep the politics out of it as much as possible here. I got my daily bleach injection for the week on last Sunday, so I'm good to go for a while there. So anyway, just minor brain damage. But so looking at the fear of math, again, think about this in terms of like labs. Like when you order a lab test for a patient, when you order a Chem 7 for a patient, do you know how the lab does that? Do you know the actual step-by-step process they use to come back with those values? No, you're probably never going to know that unless you have a background in that clin lab sort of sense. But instead, you get that Chem 7 back, and you can look at that glucose and say, wow, that glucose is high. Right? You can still interpret things even if you don't know how they actually were done in the first place. You can tell if you have a good hamburger on your hands without knowing how it was made necessarily, although it's probably a little bit more of a simple process. Anyway, point being is that you don't need to know all the details on how they came up with the numbers, but you need to be able to rationally sort of interpret them and review them, right? When I say confusing terminology, here's some of the ones that are going to come up throughout the class, and I want you to sort of keep an eye on, because these are things that are words that you may use in your day-to-day life that, again, may not have the same sort of meaning here. When I say things about confidence, like I talk about confidence intervals, it doesn't necessarily mean like how confident I feel about myself, but necessarily it's a little different here when we get into the stats here. Or I want to talk about power and how that relates to sample size and things like that. So these are some things I want you to just keep your eye on as we go forward here. And again, when we're dealing with things like populations and probability distributions, null hypotheses, I'm going to talk about quite frequently. We're going to see here that it's maybe difficult to wrap your head around the first time, but I think the more you do this and practice with those journal clubs, it should make a bit more sense there. And as I mentioned, all statistics do is report probabilities. You should be very wary of anyone that can give you concrete 100% this is absolutely going to work kind of results, because chances are they're either selling something or they're just flat out lying. So be very cautious here. If anything, I hope that you'll be a little bit more skeptical about reading things in the literature and reading things in journal articles and things like that as you get out of here, because having a skeptical eye is going to help you to be more more engaged and be more selective in terms of what you're going to actually be acting on when dealing with your patients, right? And again, certainly means you never have to say you're certain, which is okay. That's actually a really nice thing. You can say like, well, I never have to be 100% right, because I always leave myself a little bit of wiggle room there. So if someone says, well, you were wrong about this, I said, no, it wasn't. I said there's like an 80% chance it's going to work. You just happen to be in that 20%. Maybe cold comfort to whoever you're talking to, but again, it does help you and keep you a little bit safer from a certain standpoint. So another thing to look at, from sample to population, when we're talking about this is important in terms of our nomenclature here. And again, when we're doing a statistical calculation, we're not dealing with like the entire population of Earth or America or anything like that. Typically, we're dealing with a smaller sample size. And what we're doing with that information is then trying to extrapolate it or generalize it out into a larger group, a larger population, right? So there's some ways we can look at this. So for instance, we'll talk about quality control, political polls, and clinical studies real briefly here. When I say quality control, you think when Ford or GM or whoever puts a car out, they test each and every single one of them to make sure that every single thing works right. Chances are no. More often than not, they use a small sample out of a group that they have produced to see if it works or not. And if that is the case, if they can then take that sample, small sample set, and say, okay, well, these all worked fine, then the larger population that I pulled it out of should work fine as well. Now, does that mean it always works? Well, of course not, right? Just like when I talked about how drugs get approved to be put out onto the market, we were talking about how clinical studies are only involving, several thousands of people, not the millions that you're going to give it to once it gets out onto the market. So is there a chance that there is something that you can't detect when only dealing with thousands of people? Well, 1,000%, right? So when the new COVID vaccine comes out, it's only been tested on a couple thousand people, and then it goes out to the entire population of Earth. Are there chances we're going to find 1 in a million side effects? Absolutely, right? And are people going to try to weaponize that? Probably, but it just goes to show you that the sample size is going to be important, right? How big of a sample did you use of that whole population? Can I extrapolate everything about PA students out of the 62 of you if I try to extrapolate that out to the entire PA student universe? Probably not. But if I were to say use several schools from Florida, does that give me a better sense of what the actual population's like? Probably, right? So sample size is really important. We're going to talk about that more as we go forward. How about political polls? Polls always come out, this person's ahead, this person's behind, this person's going to win in a landslide. But again, they're not actually doing the vote. They're using small subsets of people. So you always have to ask, like, well, who are the people you're using? What type of voters were they to begin with? And so good polls will be able to explain that sort of thing, to look at some more of the details there. But again, things change, right? And so it's difficult to extrapolate what the polls are today. They're certainly not very predictive of what's going to happen down in November, right? Although I hope all of you are going to be voting, hopefully by mail if you can do that. But anyway, that's a really important thing. Whoever you vote for, just do it. But and then in clinical studies, again, if I'm testing a new drug, I would love to be able to give it to the entire population of people who have the disease state in question, but that's never going to be possible, either due to inconvenience or ethics or cost, or there's a gazillion different reasons why that is. But again, looking at a smaller sample set allows me to make some extractions there. I can try to extrapolate that out, and we're going to talk about how generalizable some of these results are going to be. So for instance, if I was to do a study and say how well a drug works for hypertension, but I only did it in age 60 to 65-year-old white males, that's probably not going to be super generalizable to females, to people who are non-white, who people are younger or older than that. So you got to really look at your population of the sample to see what that looks like and to see how generalizable it is to the larger group of patients who could be getting that treatment or that drug, whatever the case may be. So again, you always want to look at the population within that sample to see how generalizable it is to the larger population as a whole, right? So again, we're looking at statistical calculations. They're going to be able to do things like define the population you're interested in, right? So we need to know that sort of information. We need to know whether or not this is randomly selected, right? So if I were to, say, pay people to be in my study, then I may be getting a different subset of people than if I just pick people at random out of a phone book, for instance, right? Or that even doing that precludes that people who don't have phone numbers don't get picked, right? So you got to look at the sample, see is it really truly random or not. And then ideally what you do in a type of study would be to give 50% of the people treatment and give the other 50% a different type of treatment there. And typically be looking at a single variable, right? So if it's change in blood pressure or it's change in mortality rates or whatever the case may be. And then what we're going to do is run that statistical analysis. What we're going to be doing is making inferences, right? We're going to be looking to see like, okay, well, how likely is it this is due to chance? How likely is it that the treatment actually made it different? And then are we able to then extrapolate that out back to that whole population, right? We'll see how big of an effect we have. Is it just due to chance? Things like that. What they're not going to be able to do for us is going to really be able to, when you read an article, you can't look at and determine sort of the validity of the statistical reasoning that the scientists kind of came up with, right? So you're not going to know the mind of the scientist who ran the experiment, but that's why you have things like the peer review process and things like that to try to limit how many bad studies, quote unquote, sort of come out there. But again, when you also want to think about things like, well, if I wanted to design a study to test whether a new drug is effective in treating patients with HIV, ideally you'd run a study where you have, a pretty general population of people with HIV, and I give one of them the drug and one of them no treatment. But you can't do that, right? There's a lot of ethical concerns that come into these studies too, where it's unethical to give people without HIV treatment because we know treatment saves their lives, right? So you're going to find that a lot of times it's difficult to do studies because of these ethical concerns, right? And again, ethics are quite important. As an example, in toxicology, it's really difficult to find really high quality studies like randomized controlled trials because I can't just take 100 people, give them all aspirin poisoning, and then do an experimental treatment of 50 of them and no treatment in the other. That would be quite unethical. So there's a lot of limitations to what we can do. And even things like lifespan, like, how much does this drug increase lifespan or this treatment increase lifespan? Well, that's going to take until that person dies to really know, and that could be decades. So again, there's going to always be limitations, but we try to find ways to take the data that we have and try to extrapolate that out. And again, we do that with varying levels of success, right? And again, most of the time, you're going to find that studies are limited to the population they have access to, right? So again, you may find if a study is done over in San Francisco and they're looking at HIV patients who come to a university clinic, well, that's excluding a lot of people, right? That's excluding older patients, it's excluding those that were geographically not located near there. And so you can find data can be skewed based on who's able to be involved in it and things like that, right? Well, for instance, when we're doing HIV studies, we can't do their whole lifespan because those are too difficult to do in terms of the time it takes to do that. So instead, frequently what we do is things like CD4 count, right? We look at their CD4 count as sort of a proxy of their chances for survival. Higher CD4 count means better immune system, means they should live longer, right? But again, that only can carry us so far, and there could be limitations, that sort of thing there, okay? This is where we can look at doing things like meta-analyses and all that sort of stuff, but we'll talk about all those things a little bit later on. But just know there are limitations to what we can do with some of these studies and the statistics that we have available to us. And remember, the population really matters. Like, who are you trying to extrapolate this to? And in general, you're going to be trying to extrapolate this back to your individual patient. So like that example of the hypertension study, if you're only looking at white patients, age 60 to 65, that excludes, males, that excludes a lot of that general population who may be your patients, right? That's something you want to really kind of think about there too. And so, again, could your population be more diverse than what the population was sampled in the study? Absolutely. Were they randomly or non-randomly selected? That can be really important too. Everything should be as random as possible to try to kind of mimic how real life is in the first place. And so if we can ensure that, that can really help our studies be much stronger from a statistical sort of standpoint there, right? Anyway, so we'll get into more of these details as we go forward. I just want to make sure we have some chance to get into the actual second lecture here too. Remember that statistics typically is going to be pretty vague. Like, you always want to have concrete answers as a student, which is something that I tend to find. You guys like black and white answers, but oftentimes that's not going to be the case. And you'll see this in Farm too when you ask me stuff, and I'll say like, well, probably it's like this, or it's most likely this. Be very careful if anyone is saying that absolutely every single time this is going to happen. And beware, just because something is statistically significant does not mean it actually matters clinically at all. I can find a result of, say I'm trying out a new drug, and it drops systolic blood pressure by 2 points more than the gold standard, and it's statistically significant. Well, do you really care about 2-point change in blood pressure? Not really, right? So we'll talk about clinical versus statistical significance and why this is super important when you take and read these studies and try to apply it to your patients. Like, what does it actually matter, right? All right. And again, when I'm talking about these studies here, when I'm talking about probabilities, remember that we are taking sort of probabilities are generated from a population or a model, and then we use that to take it to our individual patient. Like, so for instance, there was a study published just recently, I just read the headline, but it was saying that patients who are obese have a 49% higher mortality due to COVID, right? That was information taken from sort of a population where they saw this data, and then you can then extrapolate that down to your specific patient, right? Okay, this patient is obese, he's more likely to have an issue if he gets COVID in terms of mortality, right? When we're doing statistics, though, typically we're working with a sample and then trying to generalize that out to the larger population. So if I did a study where I took 100 patients and all of which were obese and did some kind of intervention, then I could find out and then try to extrapolate that out to a larger sample set, usually going to be the population itself, right? So that's kind of the difference here between probabilities and statistics. Anyway, that's the end of the first section here. Just a brief introduction into kind of what we're going to be talking about here. I still have most of you online, so that's actually a pretty good sign so far. So let me go and open up the next PowerPoint here and see if you have any questions in the meantime. This is where it might be a bit more of a review for some of you if you've taken stats before, so don't worry too much about that. Or if you've not heard of some of this stuff before, that's okay. Let's see. I'll check the sticky board, see if there's any questions on. Good, no questions yet. Fantastic. Steamed hams. Yep, I love steamed hams. My favorite bits. Anyway, so getting into the second section here, let's talk about our continuous variables. Let's see what I can get through before the end of time here. It's probably like 4:10 or so. Again, you can go through the objectives, look at that. Let's talk about first our types of variables we're going to be dealing with. So first off, just to break them down into two broad categories, we're going to talk about our independent versus our dependent variables. Independent variable basically means it's either like the experimental or predictor variable. If I were to try to figure out how this drug works in men versus women, whether they're male or female is going to be my independent variable, right? That's what the experimenter is actually setting as their sort of their particular variable. They're setting that up in the first place. Or if I'm looking at, say, a study where I'm comparing two different doses of the same drug, the dose that the patients are getting, which the experimenter is setting, is that independent variable. Now, what happens at the end of that study, whether it be change in blood pressure, mortality, whatever the case may be, that's dependent on that independent factor, that's the dependent variable, right? So I gave two different doses of that drug and I was looking to see what the change in blood pressure was. That change in blood pressure is now the dependent variable for that independent variable of the drug dose they're getting, right? Or let's say we were looking at a study done to determine efficacy of a new analgesic at different doses. Again, same example I was just mentioning here. The independent variable is the dose of the medication. The dependent is the change in pain scale, right? Dependent variable can be any sort of outcome measure you can think of, whether it be change in appetite, pain scale, depression score, anything you want it to be. And you can find studies can have multiples of each, right? So I could vary at patients. I can say, okay, I want to look at male patients who are black that are getting this dose of drug versus female patients who are white getting this dose of this drug, right? You can have multiple independent variables, and then you can have multiple dependent variables. Frequently, you tend to find that most studies are going to have pretty limited, maybe one or two independent variables, and they'll have many dependent variables. So if I was looking at a new analgesic medication and I could look at pain scale as an outcome. I could look at functionality. So can they get up and walk around more? I could look at a number of different outcomes, and they're all are going to be dependent variables. So have a good idea when looking at a study, what's my independent versus what's my dependent variables. Next off, we're going to talk about the different types of variables you can have here. So first off is going to be a nominal variable. This is something that's going to be sort of a category that's going to be usually two or more possible outcomes, but there's no specific like relationship between the two. There's not one that's more or less or better or worse. They're just different, right? So for instance, if I was comparing blood types, I could say that there's A, there's B, there's AB, there's, you know, positive or negative RH factor. Those are not saying that one's better or worse than the other. They're just different, right? So there's no real degree of difference between them. They're just names, right? That's why it's a nominal variable there. If you only have two of those, so say you're dealing with, say, dog versus cat, and that's the only two animals you're really interested in, then it's a binomial sort of variable, right? Or if it's like a yes or no sort of thing. So, you know, if I was saying, do you drive, you know, a car or a truck, then that's a binomial one. Or you could then turn it to a nominal variable and say, okay, well, do you drive a Subaru or a Ford or Chevy, or, you know, so there's different ways you can sort of slice and dice these up. But the point being is that they're nominal. There's no direct relationship between the different categories, besides they're just names. Next up, it gets a little bit more complicated. Now we're getting into our ordinal variables. This now means that there is an actual rank between the different points here, and the order actually does matter. If I was doing the blood typing, I could put A, B, A, B. It doesn't matter. I could do A, B, B. No big difference there. However, though, if I was looking at pain scale, a pain scale of 10 is definitely worse than a pain scale of 8. Now, can I directly quantify what that difference is? Not really. And so that's why it's an ordinal variable. I know there's an order to it, but I can't really determine what the level of magnitude of difference is between those different points. Or when you do your, for instance, your course evals at the end of this, and you evaluate how well or poor I did at teaching you biostatistics, that's a 5-point Likert scale, right? Where you say, you know, strongly disagree, somewhat disagree, neutral, agree, strongly agree, right? How much of a difference is there between strongly agree and agree? Not really sure, but I do know that strongly agree is certainly more than agree. So that's kind of the big thing there with ordinal variables. The ones that are more likely to be used in most of, you know, the clinical studies you're going to read, they're actually going to be you're interested in for clinical purposes, are going to be more continuous variables, right? And so these are going to be something that can have any number within a given range. So look at blood pressure, right? So I know the difference between 100 millimeters of mercury of blood pressure, the difference between that and 90 millimeters of mercury is the same difference between 80 and 70. Because it's a continuous variable, the order of magnitude is always going to be the same between those values there. It's very well defined. You know, the difference between 10 pounds to 20 pounds is the same from 100 to 110 pounds. As opposed to an ordinal variable, again, it's hard to determine what that magnitude of difference is between the different variables there. Hope that makes some sense. Now, you can then break down continuous variables into two types. There's interval variables, and we'll see there's going to be another one here in a second. Interval variables are going to be basically continuously spaced. They have equal intervals, but the 0 point doesn't really matter, or the 0 point doesn't actually mean much of anything. So for example, like IQ, which is like a quotient, right? You know, it's all going to be relative. You don't really have people have 0 IQ, so to speak. And so if the 0 doesn't matter, it turns into an interval variable. I think a better example is probably going to be temperature. If you're dealing with temperature in centigrade or in Fahrenheit, just because it's 0 degrees centigrade doesn't mean there's no temperature, right? You can have negative values there. That's what makes an interval variable. The reason why this is important is because certain statistical tests can be done on this or cannot be done on these type of interval variables, because that 0 point doesn't really matter here. I can't really divide, you know, 20 degrees centigrade by negative 10 degrees centigrade and have that really make much of a sense of that. And so that's why that's really important to understand with the interval variables, is that the 0 point is sort of meaningless, right? Or the fact that like 100 degrees centigrade is not twice as hot as 50 degrees. If you were dealing with Kelvin in terms of temperature, then that would not be an interval variable, because once you hit absolute 0, you can't really go any colder than that. And hopefully none of your patients are getting anywhere close to that. Otherwise, they're probably not doing too great as it is. So an example here of why it's not super useful use interval variables on certain types of graphs and things like that. So if you were to look at, say, 4 different animals here, I don't know where they found a platypus. I mean, they went to Australia and did the study there. But if you were to compare their temperatures here, what really matters is that the different scales they're using here can make big differences in terms of the heights of these bars here, right? So again, where your starting point is can make a big difference in terms of the heights of the graphs and things like that. And because the 0 point doesn't really matter, then this degree of difference here is kind of misleading, as you can see here. Even though these are showing the same values, they can look quite different depending on the scale that you're using. So interval variables are okay. You run into them occasionally, but oftentimes we're going to be running into the other types, which are ratio variables. These are important because I can actually do ratios now with these and divide one by the other. And I'll show you an example of a table that kind of delineates this out here pretty well in just a second here. Biggest thing with ratio variables is that the 0 point does matter. So if I was doing something like mass, I don't have patients who have negative mass, right? Or I can't have someone with negative blood pressure, otherwise it'd be a vacuum, I guess. It wouldn't really make a whole lot of sense. But these are useful. These are kind of the most flexible in terms of values in which I can do the most types of calculations with, as you're going to see here. So this is really handy table to refer back to see sort of the difference between nominal, ordinal, and then again, remember interval and ratio are two continuous types of variables, and to look at the differences there. So when I'm talking about things like descriptive statistics, these are just going to be things that kind of describe what you're going to be seeing in the data, right? So when I'm doing a frequency distribution, well, that's simple. You're just counting things that are in the group, right? So I can count the number of people with A-type blood pressure, or A-type blood pressure, A-type blood type versus B blood type, right? I can count those up. And you can do those with any of these. That's pretty easy to do if you're just counting the number of something in a group. When you're talking about medians and percentiles, we'll get into that and what that means in just a moment. Most of you probably know that. But again, you're going to start to see that the nominal sort of drops out of this. It's difficult to do statistics on nominal variables because of the fact that there's no degree of difference between them that we can really reasonably infer. And so because of that, they're not super useful beyond just describing the count of something. It doesn't mean that they're useless, but it means they're less helpful here. What you're going to see, though, that the most sort of flexible one here is definitely going to be the ratio intervals here, or ratio variables here, I should say, because they allow us to do sort of the most different types of either types of statistical analyses on them and different subtractions and ratios and things like that. But anyway, we're going to get into the definitions and the meanings of these in just a little bit, so don't worry if you don't understand all of these. We're going to get into them by the time we end this, or at least get into the next lecture. So graphing continuous data, which is probably what you're most commonly going to see in a lot of the statistical or the medical literature you see out there. As I mentioned with the continuous data, this is where we're dealing with things like enzyme activity, we're dealing with temperature, oxygen saturation, could be any of these. Frequently what you're going to find is that because numbers are hard to visualize in some cases, it's easier to graph it out, right? And so I want to show you some of the different types of graphs you may run into with using continuous data. And again, it's more common than other types of data you're going to see this being graphed with. First off, though, you're going to want to know the definitions for some of the different factors here. Now we're talking about mean and median. First off, most of you probably know what this means already, right? And this is where statistics gets tough. You know what mean means, right? But getting into this, so let's say we're going to do a study here. This was done back in '92, and we're measuring body temperature, and we did it to a few hundred healthy individuals. We wanted to see what a normal temperature range actually is, right? And then we had the data on the next slide here for a subset of that, those people there. So we did it on a couple hundred people, and I'm going to show you a small subset of that. And again, when you're calculating the mean or the average, that's pretty easy to do. All you got to do is add up all the values, and then you divide by the number of observations. Or if I use the term N, that's what I'm talking about, is the number of observations you actually have there. And so here's that subset. There's 12 individuals. And we can see here that you get the mean. Well, the smaller subset here is 36.77. If you added all these up and then divided by 12, you get 36.77, right? So you would assume that the average temperature, for at least in this group of 12 people, is at 36.77, right? And you're going to find that if the data can be contaminated, right? You can have people who are outliers, and it's difficult to really see how representative these 12 people would be to the entire population, right? So I wouldn't look at these 12 people and say, well, this is definitely representative of the entire population of Earth. I bet every single person on Earth has a average temperature of 36.77 degrees centigrade. It may be the case, but it's probably unlikely because you're dealing with such a small sample set, right? So again, the number of people and number of observations you're making is really important to this because it gets to be more representative the more people that you include. What we're going to find though is that if you have a small sample size like this, it's very easy for someone to be an outlier. If someone has a fever or someone happens to have a very low temperature, it really skews your average. That's one of the big things I want you to take away from this is to realize that means and averages are very sensitive to outliers, okay? So just for example, if you're taking a test and you have one person, say the average for the class, was going into it, was maybe looking like an 88 or something like that. But then you have that one overachiever that scored 100 on. No one else could get even close to 100. That would skew the average up, right? So that might have been important in undergrad for, curving your grades and things like that. So you always hated that one person that did really well. But again, you can see that the average is very susceptible to change by outliers, okay? That's going to be important when we start to talk about normal distributions and things like that a little bit later on. But the mean is basically trying to tell us, okay, where's kind of the middle point of the data? Or what's the central tendency that all those values are trying to revert back to? Because you'll talk about this later, about this tendency for things to revert back to that mean, right? I feel like means a lot. Now the median is just going to be the middle value, right? So if I were to organize all of these values here from highest to lowest, and then I pick the middle one, that's the median, right? So the middle median value there. What's kind of interesting about that is even if I have one or two outliers, no matter how extreme those values are, it really doesn't influence my median by very much. It may move it up one or down one, but it doesn't make it move very significantly higher or lower. And so because of that, we tend to say that the medians are not influenced so much by outliers, right? They're very kind of resistant to outlier influence there in those cases, right? And so oftentimes what we can actually do is we'll actually compare the mean and the median together to see if there are outliers that are really skewing the data one way or the other. So sometimes that can be a little bit useful. There are other ways we can look at it though. So for instance, if you wanted to remove the effect of outliers, you could do that. You could trim off some of the values on either end. Now, could that skew your data in and of itself? For sure, but sometimes they do that. So for instance, you may skew it by, say, removing the top 5 and the bottom 5%. That would be a trimmed mean. And the idea is that you try to eliminate some of those outliers from skewing your mean quite so much. Okay, like Olympic diving is one example. So you don't have like one judge who's voting really low versus high, and that kind of skewing the person's average greatly, right? So that's one way to do it. Obviously, we know that the mode is going to be the value that comes up most commonly. We'll probably not talk about that too frequently in this class because clinically not super useful in a lot of cases there, especially when we're doing like really exact numbers, and it's unlikely that if you're measuring to like the hundreds place, you're going to have a lot of people kind of matching up to that same value there. So not super great, but again, doesn't really help us to determine the center of a distribution at all because it could be clumped one direction or another. So mode's not too important. So next up, we're going to talk about, looking at those temperatures, how they range from like 35.7 to 38.2. And the question is like, well, why is there any variability whatsoever? Why do some people measure higher versus lower, right? And what we're going to find is that most of the differences that we find in the data that we see is just due to biologic variability. It's just due to random chance in a lot of cases there. So it could be due to the time of day that you did it, circadian variations in the patients, their ages, their diet, their mood. All of that can really cause a lot of variability in the data. We can still figure out what the mean is, but it doesn't mean any one person actually measured that mean value in the first place, right? And so what we're going to talk about now is talking about sort of the error that kind of happens there, sort of the random scatter in the data that naturally happens. And so when looking at that, we can graph it and actually show the degree of scatter that happens here in a distribution. So looking at this, we can see the graph is showing the scatter plot for all values. So this is all the values actually measured versus that smaller subset here, right? And again, this is looking at the temperature is on the y-axis, and then you have the kind of the all group, and then that subset of 12 individuals there. And so you can see how based on the amount of observations you have, how much that scatter can sort of be shown here. And what you notice here is if you do it with all, which you have like several hundred values, notice how things tend to clump all around that median sort of value here, versus or average sort of value, versus here on the subset, you get a lot more scatter in the data. You tend to find that as when you're dealing with small sample sets, that you tend to have a lot of scatter, a lot of error in the data, and just natural error that kind of occurs, not that someone screwed something up, although that can happen, but it's not really what we're talking about here with error specifically. And so you can find that can be a challenge when dealing with studies with small sample sets because of that inherent amount of variation that can occur there. It may not be super representative of the larger sort of sample size or population you may be dealing with. Okay. So as I mentioned, some variation comes about from imprecision or experimental error. That can happen for sure. But what we're talking about here with error is the variability in the data, just the natural scatter that occurs just due to biological variation, right? Now we say bias. Bias is a little bit different because bias is skewing the data one way or another as a result of some sort of systematic error, right? So if I was measuring temperatures only from, or say I was using a thermometer that was reading a point or two high, that is going to bias the data towards having higher temperatures. Or if I was having, people do a mix of oral versus rectal temperatures, that would bias the data one way or the other. So error is natural variability. Bias is actually some kind of systemic error that is moving the direction one way or the other as a result of on purpose sort of means, or just it could be just due to poor study design, or it could be a number of different factors there. We'll talk about bias a little bit later on. Now there's some other ways we can actually describe this, other ways that we can actually graph this out. When you're looking at the data here, sometimes we use things like box plots. It can help us to have an idea of where the means are and then show some degree of scatter around here. Sometimes we'll use things like median values, and then we'll have like the percentiles marked out. So that way you can see where the 25th and the 75th percentile are, and then have a better idea of sort of where the majority of values were, and then anything outside of that is probably more likely to be outliers, as the case may be. So just different ways to kind of show the same sort of data here, as you can see. And notice here, if you're looking at the 25th and 75th percentiles here, notice how tight these boxes are versus how wide this is. That kind of shows you how much scatter there is in that smaller data set versus if you're dealing with that larger sample set of 130, right? So it kind of shows you, and you'll see that too, is that things tend to tighten up the more observations that you have. It's more difficult to do because it costs more money or is more labor intensive, but it is something you'll see generally speaking. So other ways we can do this, sometimes we like to graph things in sort of like bar graphs like this. And the question is, you could put each individual value on there, but it would be pretty tough and pretty difficult to read if you actually did that. And so sometimes what they'll do is they'll clump bits of data together into larger compartments in order to show that. And this can sort of bias the data as well when you're actually visualizing it, because the question is, well, how big of a box do I actually put these values into? Because if I put it into too small of a box, and it doesn't really show me very much. I just know most people were 37, when that doesn't really show that degree of scatter, versus if I do it into too many boxes, you can see here it's more difficult to read. It may be difficult to determine where the actual mean value was versus it somewhere sort of in the middle there. So one of the things you're going to see is that it's very easy to skew someone's takeaway from a article by how you represent the data, either with the graphs that you're using or the data that you're including and maybe excluding. And so you always want to keep sort of a critical eye to that, to be like, okay, well, are they just showing me what they want to show me? What's the actual data really showing? So that's an important thing I want you to start to think about when reviewing the medical literature. All right, so how do we quantify that scatter? How do we actually get a value for that? And so this is where our standard deviation comes into play. Now, again, I'm not going to have you calculate these out specifically, but I want you to know what it means when I say standard deviation, because this will be important. We start to talk about things like 95th percentiles, or confidence intervals, I should say, and talking about things like that. So basically, if you were to imagine your mean value being sort of right there in the center, and every other value sort of varies around that mean, right? Everything kind of centers around that mean. The standard deviation is a quantity of how much variation there is in that data. So a lot of standard deviation, a large standard deviation, means there's a lot of scatter. There's a lot of distance between those values in that mean, versus a very small standard deviation means most of the values are pretty close to that mean. They're right in the middle. And so the bigger the standard deviation, the more scattered, the more spread out that data is going to be. And so again, when we're looking at something like a normal Gaussian distribution here, a normal bell curve, what you're going to be able to find is that we can actually quantify the percentage of values that should be fitting within each of these standard deviations here. And we're going to find where we talk about, something being 2 standard deviations away or 95% confidence intervals, that we're going to come back to this. So just keep this in the back of your mind here and for a little bit. So anyway, what you're going to find is that roughly about 2/3 of the observations in a population usually lie within the range defined between -1 standard deviation and +1 standard deviation. Now, the bigger that standard deviation is, you may widen this out, but still roughly 2/3 of values should be within this range here, between -1 to 1 standard deviation. So it looks about 66 some odd percent there. It's a little bit higher than that, but you get the idea. what you're going to find is too that when you start to go out beyond that, so you include -2 or +2, you're going to actually closer to 95% of the values are going to lie within 2 standard deviations. So that 95 is going to be an important number to keep in your mind as well as we go forward and start to look at some of these interpretations here. So if you were to look at this in the temperature example, that larger sample set of 130 people, that mean temperature was 36.82 with a standard deviation of 0.41. So that means that if you were to look at that mean of 36.82 and you go minus 0.41 centigrade and plus 0.41 centigrade to that mean, you're going to get roughly 2/3 of the number of people are going to be within that range there. And again, roughly speaking, you tend to find that when you have smaller sample sizes, that may be violated to some degree. But for the most part, with larger sample sizes like this, yeah, 2/3 of the value should be in there, right? And so that's why you end up looking at some of the box plots. You can see that they can actually show you between 1 and -1 standard deviation to kind of account for where 2/3 of those values are going to be. Now, this doesn't tell you anything about outliers necessarily, but it kind of shows you where most of the data should be clumping. And you can kind of see here, if you were to imaginarily draw these lines, yeah, probably about 2/3 of the values are within that. Okay, so it's a pretty general assumption there. So how the computers actually calculate this out is by looking at what the mean is, and then taking each value and then figuring out what the difference is between that value and the mean. And then they add those all up together, and through some magic, they form the standard deviation. Am I going to ask you to calculate that? No. Can I calculate that if you had a gun to my head? No, probably not. But the factor is that it's going to help us to determine that degree of scatter. That's what I want you to know. This is the formula for it. But again, I don't really care that you know this right off the top of your head. Point being is that roughly 2/3 of values are going to be within 1 standard deviation plus or minus, and then 95% should be within 2 standard deviations there. So already you can kind of say like, okay, well, with some degree of confidence, I can say where the majority of the values are going to be for something around the mean. I can say, okay, well, I know it's going to be probably plus or minus 2 standard deviations here. And actually, you could do this the same thing too. If you looked at all your GPAs, for instance, you could figure out what the standard deviations are and actually find out, do your values do that? We'll talk about normal distributions in a little bit, but we'll see that that actually holds true in a lot of cases, which is nice. You can go out 3 standard deviations, that's like 99.5%, 0.7%. But in general, just remember 2/3 for 1 standard deviation away, either direction, and then 95% for 2 standard deviations away. That'll be the more common things we'll talk about. Okay, so that brings us to the Gaussian distribution, otherwise known as a normal distribution. What does that mean? Remember, normal here is much different in a statistical sense than what normal means in your day-to-day life. Like me, I would be considered to be very abnormal, even though I might fit into a normal distribution. There's tests for normality, as we'll talk about in a little bit. I've generally failed every one I've ever taken, but take that as you will. Anyway, so when we look at that bell-shaped curve, that's a Gaussian curve, right? That's telling us that if you had a truly random sample set and you looked at any value, if you look at blood pressure, you looked at heart rate, you looked at anything, if you were to plot all that out in the whole population, you should get a normal distribution that looks like that bell curve, right? There's some things that can skew that one way or the other, but for the most part, if a sample is truly random, that's what it's going to look like. Most values are going to tend up towards the mean, and you're going to find that the further and further away you get from that mean, the rarer those values are going to be. You're going to see that it's much more unlikely to get values of either extreme, because most values tend towards the mean there, right? They'll have that central tendency that happens. So as I mentioned, if you were to actually plot out all those data points there, you end up seeing that bell-shaped sort of curve. That's why we call it a Gaussian distribution, the normal distribution. Most people don't know this, but if you were to extend it out the x-axis here, you actually find the rest of the bell curve, which is where Nessie lies. So if you ever were curious, that's where she went. So anyway, so when you're looking at the ideal Gaussian distribution, you can again see that the mean is going to be here in the center, and then -1 or 2 standard deviations are going to include all of those values that I mentioned before, the 2/3 within 1 standard deviation, and 2 standard deviations will have about 95% of those values there. And again, as you get further and further away, you notice that the number of values are going to be pretty extreme. It's going to be very difficult to find values this high or low on either end as you get further and further away from the average, right? Most people tend towards the average. Those outliers are quite rare. That's why they're outliers, right? And so what we're going to see is that the area under this entire curve is going to be that entire population, right, that you're looking at. Could be your entire sample set, entire population, however you want to define what your distribution is. And so you're going to find that oftentimes those scientific papers, they're not going to give you every single data point that they have. That would be pretty boring to read, and your scientific journals would look like phone books all the time. But frequently, instead of giving you every data point, what they'll do is they'll show the mean, they'll show the standard deviation, and then you can kind of imagine based off of that what the Gaussian distribution would look like. You can see how spread out it is, how tight it is. You can imagine that just based off knowing what that standard deviation is. So you don't need a ton of data to be able to figure out what those distributions actually look like, which is pretty neat, I think. You can just kind of imagine it in your mind of where those values actually lie. So again, when looking at a standard normal distribution, I'm talking about the mean value. We're going to decide that's our 0 point. That's kind of the center of the graph there. And when we go up one or down one standard deviation there, that's going to be calling us that normal sort of curve, right? And so you can talk about a z-score. And a z-score is talking about how far away or the number of standard deviations you are away from the mean. And so sometimes you'll see people talk about z-scores. Sometimes that's just referring to how many standard deviations you are away from the mean, whether it be +1, -1, +2, -2, whatever the case may be. That was what they're referring to. And you can have, increments of that as well. You can see here 0.67 standard deviations away on either end would give you 50% of the values, whereas that 1 was at 2/3, as I mentioned, and then 2 being the 95%. Again, this is probably going to be the most common thing we're talking about, especially when you get into like p-values and things like that. So definitely remember 2 standard deviations away on either side is going to give you, I'm bolding it because it's important, 95% of those values, okay? As we talk about p being less than 0.05, can be directly related to that 95%. Show you. Okay, and as I mentioned, normal distribution does not define what the normal limits are, right? So just because someone, say normal temperature is 37 degrees centigrade, for instance, just because someone comes up outside of those 2 standard deviations does not mean that they are abnormal. It might be normal for them, right? And so that's why you can find that patients, say for instance, you did a blood level for a drug and it came back lower than the therapeutic range. It came back too low, but the patient's doing fine. They're not having side effects. They're having no issues with it. That's normal for them, right? So that's why it's really important to consider not just treating the number, but you got to look at the patient themselves, because they could be an outlier. They could be outside of that normal. Doesn't mean that it's wrong for them. It just means that it's not within that typical normal distribution. It's rare that you would find someone that falls outside of that, but that could be their normal, right? So some other things we can look at too include what we call the standard error of the mean. This one doesn't get reported too frequently, but what it is useful for doing is helping us to know how closely we are representing our true population. Because again, when you're looking at, say you're doing any kind of study, ideally you'd like to use the entire population of Earth or the US or whatever the case may be to get a really good representation of how people would respond to a treatment or whatever the case may be. But that's going to be logistically impossible, right? So you want to figure out, if I only have 30 people, how representative would that actually be of the true population? And you may find that depending on the sample, it could be pretty representative, or it might not be representative at all, because those 30 people, if not selected randomly, could be pretty biased one way or the other, depending on how I selected them, right? And so you can find that even though the standard deviation for a particular value might be pretty large, the larger my sample size is, and remember, sample size is going to be n, right? That's a variable there. The bigger this is, it's going to draw my standard error of the mean down, because I'm more representing that entire population, right? So if I had, if I was able to measure, if I wanted to know the average temperature of everyone in the U.S. and I measured everyone in the U.S., I would be very sure that I knew what the actual average is, because that standard error of the mean would be 0 at that point, because my n would be so large, it'd be 300+ million people. But since that's not oftentimes feasible, you're gonna be using much smaller values, and so that standard error of the mean can help you to determine how close to the actual sample size you should be getting. Now again, it's not telling us how big of a spread of the data there is, but how well we know what the actual population mean is. Because again, why do you care about what this 12 people, what their actual average temperature is, unless you're going to take that and then generalize it out to that population? And so it's good to know how likely it is that those people, their average, how well that equates to what the actual population average is itself, right? We want to be able to know how generalizable, how we can extrapolate that, how likely that is to truly be the case, right? So anyway, and again, I'm not going to have you calculate standard errors of the mean. I just want you to know that these are useful because they're going to help us to determine what our confidence intervals are. And confidence intervals are going to be another really important concept I'm going to try to hammer into you guys. P-values, confidence intervals, those are going to be our bread and butter sort of things we're going to be looking at when we're evaluating the literature to see if what they found was statistically significant or not. So kind of keep that in the back of your mind. Now, I say confidence interval of a mean. Basically, what this is trying to say is that, let's say we're dealing with our body temperature example here. Like, so we have our n of 130 here, and then we have our n subset of 12, right? And so using the standard error of the mean, using the standard deviation, I can calculate what the confidence interval, the 95% confidence interval is of those values there, right? You're like, what's a 95% confidence interval is? What it's trying to do is trying to say, well, if I were to then extrapolate that out to the entire population, whether it be people in Florida or the US or whatever I set that up to be, how likely is it that the true average of the population is contained within these values here, right? Because I'm not going to take that 130, I'm not going to get their mean value and say, well, I know the population, the true population mean is this. Because anytime I say I'm 100% right, I'm guaranteed to be 100% wrong, right? It's always the case of it. Anytime you're really sure about something, they prove you wrong. So what I can do instead is I can say, well, I'm 95% sure between these two values that the true population mean is somewhere in here, right? 95% sure is still pretty sure, but it gives you that 5% wiggle room to say, well, if I'm wrong, it's pretty low chance I'm going to be wrong here. I can say that between these values here, right? Now notice here, if I use that subset of 12, how the confidence interval changes. What do you notice about it? Well, notice how it gets much larger. The range here is much bigger because I'm using a smaller subset of people to be able to extrapolate out of that whole huge population. So the bigger the n is, the tighter your confidence intervals are going to be. The more sure, or a smaller subset of values, you can say, yeah, I'm pretty sure the confidence or the population average is somewhere between these two numbers here. Okay. The confidence intervals are really important. It's trying to say that if you extrapolate that out to the population, how sure are you, 95% sure, that the true value is between these two numbers? Okay, I'm going to give you a lot more examples of this in the future, so don't worry too much if you don't get it right now. But we're going to talk about this over and over again, so don't you worry. So again, it allows us to be, 95% sure. You don't have to be 100% confident. Again, it'd be very difficult to be 100% confident here. Note here that the confidence interval is always going to be centered around the sample mean. So it's always going to be the outer bounds. The middle point is always going to be the average, right? The actual mean of the sample that I have there. Now, again, because I said the population mean is not known and cannot be known because I can't actually measure every single person there, just know that this is our way to sort of estimate, right? We're using the statistics helps to estimate what the actual true value should be. Is CI always 95%? It's a good question. No, I could do 90% confidence intervals. I could do 99% confidence intervals. 95 is the most common, though, I will say. In statistical testing in the medical literature you're going to see out there. So what's interesting though is that if I lower my confidence, if I say, well, I only want to be like 50% confidence, I'm sorry about that noise in the background, I have no idea what that is, but let's say I want to be 50% confident, I can then pretty much narrow down that range because I can be 50% wrong, right? I don't have to be all that too certain of those actual values there. But if I want to be 99% sure, I got to give myself a lot of room to work with because I only got 1% chance I'm allowed to be wrong. Okay. So anyway, so again, this is our way to try to extrapolate out to that whole population mean. So again, what values help us to determine the confidence interval of that mean? Well, one, we need the sample mean. We got to know what that is. And then we're going to get the confidence intervals that's centered around that. To go into that, you need to know what the standard deviation is because that's going to be telling us how widely scattered that data is, and that's going to help us to determine the calculate out what the standard error of the mean is, and that then goes into calculating the CI. What you're going to see is that the width of the CI is proportional to the sample standard deviation. Okay, so the wider my standard deviation is, the wider the variability in the data there is, the wider my confidence intervals are going to be. If the data is really tight and really packed together, my confidence intervals are going to shrink. And that's what you're typically looking for. We like to be able to shrink that down as much as possible. So you either can do it by decreasing your standard deviation, which you don't really have a direct effect on because you're just measuring stuff in the sample, but you can change it by modifying your N. By including more people, I can get a much better idea of what the actual population looks like. So anyway, so as I mentioned, sample size, larger sample size is going to have much closer to that population mean. Even going from 12 to 130 is a huge jump, right? If you're lucky, if you run a study to even get 30 people, 30 people is kind of like the minimum number to where you can actually make good decent statistical analyses, but the bigger, the better, as it turns out. And then, as I mentioned, the degree of confidence also is sort of that third variable that I can modify there, just like Kelly was asking. So if I'm wanting to go with a smaller confidence interval, I can go with the smaller degree of confidence. I can go, if I want to go 50% confidence interval, I can then shrink that down because, again, I have a lot of wiggle room to be right or wrong. But that doesn't really help us out clinically, right? Because I don't want to say, well, I'm 50-50 that I'm right on this. That's not very confident. If I were to say I'm 95% confident, though, that's going to have to widen out that confidence interval additionally to include more values. So that way I'm more likely to be right based on having more numbers to work with, okay? So again, how confident am I that the true population mean falls within a given range of values? That's basically what it's trying to tell us. So some of the assumptions we have to make, because again, when we're dealing with data, we have to make some assumptions, even though I told you, I think probably in another class, not to make assumptions, but we had to do some. So to interpret that, you have to accept the following assumptions. So one, that our sample is random or representative of the larger whole, right? So that way I'm not just getting male patients, or I'm not just getting people of a certain age or whatever the case may be, unless that's the population I'm curious about. If I just wanted to know about white men 60 to 65, then I could just collect those people and that would be a representative sample. It's not very generalizable to the whole population, but again, I'm setting the definitions here. If I'm looking at, and so when I'm doing that, if I'm assuming a normal distribution, I have to assume everyone is randomly selected from that population. What you're going to find is often this isn't true, but you can still try to interpret the data as you can, and this is why it's really important when you're reading studies to actually look at the people that they include, look at their demographics to see, is this representative? Is there a disparity between ages between groups, or in the sample versus the population? Is there disparities in gender or comorbidities or any number of things that goes into the demographics that could be skewing the data, making not really representative of the true population, right? This is when we talk about convenient samples, where you're kind of like picking people just as they walk through the door, you're offering them $100 to come join your study. That may bias it one direction or another versus a truly random sort of sample there, right? And then you got to assume that they're independent observations. So this is really important too. Each person needs to be separate from all the others, meaning I don't want people who are siblings, right? Because siblings carry some genetic features that are similar to one another. They could be biasing the data, right? I don't want to have people measured twice, the same person measured twice. Maybe I'm offering that $100 and then one person comes through and they put on a mustache to get another $100. That would violate the assumptions here. I need everyone to be independent of one another because again, groups could then, that are related, could skew the data one way or the other. Other things too, again, the accurate data, it's only valid if the values I'm actually measuring are done correctly. So for instance, doing different emails on trials. Yeah, tell me about it. Probably opened up, I don't even want to say that. I was going to say open up America Online AOL accounts, but that's probably, most of you don't even know what that is for the most part. But used to go on vacation, we'd open up different AOL accounts just to get phone line connections to the internet. That's how old school it was back when I was on vacation. But anyway, so when you have to make sure that the data is actually accurate. So for instance, if I was doing rectal temperatures and then someone started doing temporal temperatures or oral temperatures, that could skew the data. So you have to assume that's being done correctly. And then is it even an event I really care about, right? So is it something that if I extrapolate it out, does it really matter? So again, when looking at this, you may be looking at core body temperature, but random oral data was gathered. Again, you got to be able to throw that out because it's not really relevant to what you are really actually caring about there. And then the population needs to be distributed in a Gaussian manner. So you're assuming that you're pulling from a totally random sample that follows that Gaussian distribution. There's going to be more on this later, so don't get too hung up on this. But again, we're going to talk about our assumptions of whether data is normally distributed or not, and that's going to influence what type of statistics we do. So if you hear me talk about parametric versus non-parametric, that's where this is going to come into play. So just hang on that idea for just a little bit longer there. What happens if the assumptions are violated? Well, typically you're going to find the confidence interval will be too optimistic or too narrow, and so I'm going to narrow up that confidence interval, and the actual population mean is actually outside of that, either one way or the other. And so what you're going to find is the true confidence interval was probably larger or wider than what I actually calculated if you violate those assumptions. So let's do a little bit of Q&A, and let's see here. I screwed it up because I'm not doing it in presentation mode right now. But just kind of go through and you kind of self-check yourself on a few of these questions here as I wrap up. But can the mean or median equal 0, and can it be negative? The answer to that is actually yes, because you can find it depends on what you're measuring. So does the value you're looking at, does it have negative values, or can it be zero, right? I can look at changes in pain scale, and that could be a zero, right? So it just depends on what values you're looking at. It doesn't depends if it's an interval or a ratio sort of variable there, okay? Which is larger, the mean or the median? It really depends on the data. It depends on the outliers and where the outliers are pulling the mean either higher or lower than the median. Just depends, right? Are mean and average synonyms? Yes, you can use either one of them interchangeably, no problem. What units are on the mean or median? Same units as the data. So if I'm measuring temperature in degrees centigrade, the average is going to be measured in that same variable there, same unit, right? Can the mean and median be computed when n equals 1 or n equals 2? You're going to find that you can't really do a mean with just a value of n of 1 because they're the mean, I guess. They're the only value you have there, but it doesn't really make a whole lot of sense. As soon as you get 2, then you end up finding that you could do a mean and a median. Typically, if you find that the median is kind of between 2 points there, so if you had those two individuals, you would just take the average of those two values and get the middle point there. So that's typically what you do with medians there. And then if you're looking at percentiles, is the 50th percentile the same as the median? Yes, that is. Okay. Can the standard deviation ever equal 0, or could it be negative? It's not going to be negative, but the standard deviation could be 0 if every single value you measured was identical. Is it ever likely to occur? Definitely not, but it could happen, right? In what units do you express standard deviation? Again, it's going to be the same units as the data. So for instance, if I was using your GPA as try to figure out what the average GPA for your class is, and then what the standard deviation, it'd be in grade point average, essentially. So the same units there. Standard deviation be computed when n equals 1 or 2. It would not be able to when you just have 1, because there's no variability in the data. If you just have one data point, 2, then you could start to figure that out, even though it wouldn't make a ton of useful information from that. Is standard deviation same as standard error of the mean? No, those are pretty different, right? You use standard deviation in the sample size to figure out standard error of the mean, but it doesn't tell you the same thing, right? Standard error of the mean is trying to say how closely are you representing the entire population. Standard deviation just means what's the variability in the sample set that you're specifically looking at, okay? Gaussian distribution the same as normal distribution? Yes, they are interchangeable. I'll probably use either one pretty commonly there. And then are all bell-shaped distributions Gaussian? All Gaussian distributions are bell-shaped, but not all bell shapes are Gaussian. There are tests we can run to actually look for that. There's tests for normality, outlier tests, etc., that can help us figure that out. So just know that not every bell-shaped curve, can't look at it and assume it's Gaussian. Okay. Why 95% confidence? It's pretty arbitrary. I don't know. I guess it's confident enough for what our purposes are for. We'll talk about later on false positives and negatives and things like that, and how that can be influenced by this. But yeah, it's pretty arbitrary. Like some things in medicine, it just is. Does confidence interval of a mean quantify the variability? No, right? So standard deviation is showing us the scatter, but what is it really trying to tell us is that what the actual population mean would be is between these two values, right? So again, if we have a sample set of 100, what's the confidence? I'm saying I'm 95% confident that the true population average is somewhere between these numbers here. That's what that's trying to tell us there, okay? Is 95% confidence interval of the mean always symmetrical around the mean? Typically it is, but it depends on how it's calculated, but usually it's going to be symmetrical around there. Would a 99% confidence interval be wider or more narrow than a 90%? Remember, as I increase confidence, I have to give myself more room to wiggle there, so I have to give myself a wider confidence interval. If I wanted to be less confident, I could then shrink it down. But again, less confident I am, the less stock you could really take that that's even a true value or not, right? What does the standard deviation quantify? Again, just scatter how far from the mean the actual values are in general. And then what is standard error of the mean? I talked about this already. Again, how representative is it going to be the actual sample there, right? So again, as the n gets bigger, standard error of the mean is going to get smaller. And if you had the entire population, standard error of the mean would be 0, right? Let's see. Are the standard deviation and the standard error of the mean expressed in the same units? Yep, they're the same units. Standard error of the mean is going to be always smaller, though, because that has the square root of the n, or the sample size, in the denominator. So that ends up always being smaller than standard deviation. And as standard deviation gets smaller, so does the standard error of the mean as well. Let's see, if you increase sample size, is the standard deviation expected to get larger, smaller, or stay about the same? So standard deviation is going to be less predictable as you increase sample size, because you could start to include more people that increase the variability in that. So that one's not going to be quite as predictive, versus if I get a larger sample size, standard error of the mean is always going to get smaller, okay, as I get closer and closer to the actual population size. And that is the end of this section. Some of these will have some Q&A at the end there, just to kind of check your understanding. But yeah, that's the first two sections. We did it in time, which is fantastic. That's what we usually shoot for. Let me check to see if there's any questions on the sticky board. Nothing there. There's probably another one of those brain melting kind of topics, or it might be totally reviewed and it was super easy. So you know, this is always something I went to school to be a pharmacist, not to become a biostatistician. So I could always use tips. If you guys know of a different analogy or something, a better way to explain something, I'm always game to hear that, because I always like to learn new ways to teach this. I'm pretty sure the first time I ever did, it was pretty much more painful than it is now. I will say that. See, Jonathan's asking, can you clarify CI versus SEM? Yeah, so standard error of the mean is used to calculate the confidence interval. And in fact, when you read the medical literature, you'll probably never see standard error of the mean expressed. They'll probably never tell you that value, but they will give you the confidence interval, right? So again, it's just trying to tell you the standard error of the mean is just how closely representative is your sample size, whether it be 12 or it be 1200, to the actual population. And again, as the sample size increases, standard error of the mean gets smaller, and that helps us to narrow down our confidence interval, because as we get closer to the actual population, we can say with more certainty that the actual population mean is between a smaller and smaller subset of values there. Let's see, can we keep political comments, jokes out of future lectures? Someone asked there. Sure, but some of the stuff is relevant. So, if you take something as a joke, that's okay. We can always have a topic about it or talk about it. But yeah, some of the stuff is relevant. So, if it's coming up in the news and I think it's important for you guys to hear about, I think you guys should hear about it. So yeah, but I always try to keep my jokes as unoffensive as possible. But yeah, if I offended you, I apologize. But let's see, what other questions do you guys have? So about tomorrow, so unfortunately, due to the family circumstances for which I'm in Georgia right now, I will not be able to do Farm Live. I'm going to put an announcement about this as well, but I've already recorded that, so I'm going to post that up, and so you can watch that tomorrow at the normal time or whenever you wish. I would definitely recommend watching that prior to the next farm lecture, right? So make sure you watch that prior to. You can watch it live, not live, but you can watch it during the time that's allotted for tomorrow, so that will be up and posted for you. So check that out. Another question I had here is, can you explain why 99% confidence interval is wider than a 90% confidence interval? Yeah, definitely. So imagine I was trying to say I would want to say with some degree of certainty what the actual average of a population value is, whether it's let's say temperature, right? So the actual average population temperature for the US, for instance. If I wanted to be 50% sure that I actually captured that average value, I don't have to have a really huge range there, because again, I can be 50-50. I can be, if I'm wrong, then I had a 50% chance of being wrong anyway. As I want to be more and more confident, I'm being more and more sure that this is the actual value, right? And so to be 100% sure, I could, say, well, I know the actual average value of the population is somewhere between 0 and 100 degrees centigrade. Now that's not super useful, because of the fact that, well, of course it's probably between 0 and 100, like no one's going to be 0 and no one's going to be 100, right? But to be 99% sure, you have to increase that range of values that it could be in order to make sure that you are going to be right, right? Because you're only saying there's a 1% chance that I'm wrong, so you have to give yourself a lot of room to say that. Versus with a 90% confidence interval, there's a 10% chance you're wrong, so you can have a much smaller range of values in order to look at that and be incorrect there. So see, Kaylee says, so our next farm block for 1-4. But we only got halfway through 1-2. Are we expected to complete both in tomorrow's time block? No, I did another roughly hour and 20, hour and 30 minutes there. So I didn't even finish up the bugs and drugs section. So don't worry, I'm going to pick up right where I left off and go from there. So no worries about that. I will keep you guys on track. It's a big section to start out with, so that's why it takes us a while to get through it. So, all right, any other questions? If not, that was a lot of information, so go and think back on that, let it kind of simmer a little bit, and we will carry on. Yeah, you guys have a great day. Yeah, you guys have an awesome weekend. I will see y'all later.